Elizabeth Riley, and it is my very great pleasure to introduce you to my good friend, Dr. Matt Southward, who will be talking with us this afternoon. So Matt started his career trajectory at the University of Chicago, where he graduated with a Bachelor of Arts in Psychology. He then got both of his master's and his Ph.D. from Ohio State, and then completed his pre-doc internship, a clinical internship focused on dialectical behavioral therapy and borderline personality disorder at Duke University. And he is now affiliated with both the Department of Psychology at the University of Kentucky and the Clinic for Emotional Health, where he is a postdoctoral scholar. And so Matt is getting ready to start on a career development grant, funding him to continue his work on personalizing and optimizing evidence-based psychotherapy treatments, which will be his focus of his talk today. So I hope you enjoy listening to Dr. Southward talk to us this afternoon. He's a wonderful friend, colleague, fierce board game competitor. So I'm excited to listen to him talk about more of his work. So take it away, Matt.
Thank you, Dr. Riley, and thanks to everyone here. I really appreciate you all coming here. I appreciate Diamond, Nick, and Dr. Riley for having me, for the invitation. And hopefully we can get into a little bit of discussion about what we know, what we don't know, and what we want to know about how we can find our ideal psychotherapy treatments early, optimize our treatments, and make them as efficient for people as possible. So just to kick us off, I wanted to kind of talk through how our current psychotherapy process works. And just as background, I'm also providing therapy services both at Duke beforehand and currently here as a postdoc. And so a lot of times what we do is we welcome people, ask them to sit on our couches and remind them that everything is fine, everything will be okay. We then kind of go through the list of difficulties, problems that someone is experiencing, whether with family, whether at work, whether just emotionally, to try to get an overarching picture of what it is, what are all these things that they want to work on. And then we spend, the rest of the time talking, trying to understand what's going on for folks, trying to understand what we want to target, trying to understand what works. Are we as a therapist going to work well with this patient? Are there other resources they need? Things like that. But of course, at least at the start, it can kind of feel like we're not exactly sure where this treatment's going to go. There are, of course, humans are complex, and there can be so many avenues and side streets and things that can come up for folks that we don't expect, and we're not exactly sure how to make decisions as a therapist without any kind of guidance. So part of what I want to talk today about is the relevant decision-making process that clinicians can implement and how research can inform that a little bit. Now, part of the impetus for my research and for this talk is the quickly changing landscape of mental health care. So really what I'm thinking about here is how mental health care is funded, who's paying for it, and what are they paying for. So currently, there are really kind of like two competing models for how we pay for healthcare. There's a fee-for-service model and a fee-for-value or a value-based care model. So in the fee-for-service model, which really dominates mental health care right now, you are reimbursed as a therapist for whether or not a session occurred. Doesn't matter what happened in that session, just matters that it occurred and you can justify how long that session lasted. This is super easy as a therapist to track and to report, and it's cheaper upfront, at least as the provider, to just document, yep, this happened, this is what I did, it was a 30-minute session, a 45, 60-minute session, and this is generally what we covered. However, you can easily imagine, I'm sure as many of you, if you are practitioners or have been involved in the mental health care field, you know that this is a big problem because it's clearly incentivizing us to take patients that we know can come regularly for ever, for as long as a person can afford it. Because what this is incentivizing is just the attendance of sessions. In a fee-for-value system or a value-based care model, you are asking questions like, was this session actually helpful for a person? Is this course of treatment actually benefiting a patient in a way, rather than just assuming a session occurred, therefore something good happened. You also, in a value-based care system, really want to get a better sense of patient outcomes. So thinking big picture, right? You want to be able to track, okay, are people improving? Are they getting better? Are they functioning better? Are they accessing other medical services less frequently? Are they happier, healthier, like more well-rounded people? Do they have stronger social relationships? It really kind of like expands the horizons of what do we mean by better patient outcomes. And the overall goal of the fee-for-value or value-based care model is to lead to cheaper mental health care over time for the population. So there might be more upfront costs in setting some of these things up, or tracking some of these outcomes, or moving the incentive structure for providers and providers adapting to that. But over time, if we're really trying to optimize these outcomes of benefits of sessions to patients, that should lead to cheaper healthcare over time, because people are getting in, they're getting the care they need, and they're getting out again. Now, this has already started to be implemented, at least starting in 2019. Some of these processes, some of these mechanisms were rolled out to mental health care providers, clinical psychologists who are billing Medicare. And the idea being that as goes Medicare, so will go other private insurance companies. So a lot of what I'm going to be talking about today is about not only how do we make decisions in psychotherapy, but also framing it in this larger context of why these decisions might be important. And I want to argue these decisions are important because if you are trying to make some of the most optimal decisions or design kind of the optimal course of care for a person, this ultimately might benefit your bottom line, or it might benefit the bottom line of an organization, given that you can make treatments more optimized, efficient, and more easily accessible for patients by not keeping them around forever. And so you give more people in your population access to your healthcare resources. So there, as I and some of my colleagues have kind of conceptualized this, there are really 5 choice points that therapists have. There are many, but these are 5 kind of clear ones that have received some research attention, that therapists can make a decision about how am I going to personalize this treatment for this patient that I'm seeing. And I'm kind of laying this out. This arrow really refers to the duration of therapy or time points within therapy. So at the very front end, you have the choice of what treatment package are you going to deliver. This is going to be, of course, informed by what treatments you actually know or what your team knows. But treatment packages, things like cognitive behavior therapy, interpersonal therapy, psychodynamic therapy, all of these things are treatment packages that could be delivered to a given patient. And so currently, people will pick a treatment package, again, based on what you know. If someone comes to me for trauma, I'm going to think about cognitive processing therapy or prolonged exposure for them. Other people know EMDR, eye movement desensitization and reprocessing. Other people know general cognitive behavior therapy or psychodynamic treatments for that. However, again, this is not necessarily the most optimal way to do it because it's simply limited by what I know and what I can deliver. We can then ask, okay, well, what does this patient actually need? So within a bigger treatment package, there are specific things that I can do for specific patients. So again, for instance, someone who comes with a trauma background, I might be focusing more on how that trauma is impacting them today. Whereas someone with depression but doesn't have a trauma background, I'm going to be asking them questions about how do they stay motivated? How do they do things that are interesting and enjoyable for their lives, and trying to do things to promote that instead. So even within these treatment packages, there can be tools that we can pick and choose to try to match different patients. But not only you could just give these tools haphazardly, but you also want to sequence them in a way. You don't necessarily want to start someone in trauma with an exposure that is the top of their exposure hierarchy on day one. They may not even come back to see you on day two. So you want to be thoughtful about, okay, like how do I sequence this treatment? How do I sequence these tools in a way that makes sense for this patient and helps them to really get the most out of therapy? Next, you want to figure out how often are we going to meet? So, given wait lists, a lot of times patients are meeting every 2, 3, 4 weeks. Treatments as they're currently designed are often designed to be delivered once a week, but you can imagine varying that for a lot of reasons. And we'll talk about reasons to mix that up and what the evidence says about that. And then finally, there's just the decision of, well, how do I know when this treatment's over? There are, again, many reasons why a treatment might end. A patient might be better. They might run out of money. Their healthcare provider may not cover it anymore. They're worse and they don't want to do this anymore. So there can be so many reasons why the treatment might end. But if you can control that, or you can be thoughtful about how to do it, there can be some real benefits to making some of these decisions. All right, so at the front end, how do you pick a treatment package? What factors might go into that? So I'm going to walk through at least a couple of models that researchers have studied to try to get when you have the choice, to try to get a good decision for the right package for the right person. So one fairly straightforward way folks have looked at is called shared decision making. And so, as you can imagine, this is where, rather than the patient coming into the therapist and saying, I have this problem, and the therapist saying, okay, this is how we're going to deal with it, you together try to make a decision. So the patient might say, I have this, again, using trauma as an example, I've had trauma, I'm living with some of these difficulties, and the therapist, I could say, hey, we could do prolonged exposure and it would involve these processes. We could do cognitive processing therapy and it would look like this. And then together you can kind of see which one of those matches the patient's values, what matches their preferences, what are they more willing to do and stick with. And so you kind of together can figure out what might be best for the patient. Now, you might want to know, okay, does that actually help people to get better? And at least the preliminary research on this is that there are no significant differences in outcomes whether you use a shared decision-making approach or don't. So whether you collaborate with the patient or you tell them this is what we're doing, if you've got an effective treatment, it's probably going to work, at least for depression here. At the same time, there are some significant differences in how satisfied patients are with the care that they get. So if you do involve patients on the front end, they will tend to have a little more agency, a little more sense of control, a little more investment in the treatment, and so might report being more satisfied overall with their sense of care, or with their course of care. And getting back to kind of the fee for value process, this could factor into your value equation. Providing better, more valuable care to your patient population may involve not only good symptom outcomes, but it might also involve better patient satisfaction, as this can, promote them just being happier, healthier people, communicating this to loved ones, things like that. However, if you do want to optimize your outcomes, there are also some really interesting machine learning models that are being applied these days. And so in these models, you use patients' baseline data and then other patients who have gone through therapy to try to predict your patient's optimal treatment. So basically what you're doing is you're saying like, okay, here you might ask your patient to fill out some background information. And if you can combine that with basically matching them to other patients who have gone through that treatment before, and you've seen kind of how their care or how their symptoms change over time, you can get a good estimate of how they might do and what package might be best for them. So one example of this is this machine learning model of treatment selection. So what we're looking at here is just, so end HRSD is just a measure of depression symptoms at the end of treatment. And then these kind of like shaded bars here indicate in one study, people who just happened to be randomized to the treatment that this machine learning algorithm predicted would be their optimal treatment, and people who just happened to be randomized to a treatment that was not predicted to be their optimal one. And so here you see some small differences between folks who are randomized to their optimal one or non-optimal one. But then that could be there could be some noise in this data, in that there are some people for whom it really doesn't matter as much what treatment they get. And there can be other people that would be a really big difference between the types of treatment. So if you do select just those people where you can kind of like cut out the middle people that would probably do well in either condition, and you just look at the people who are likely to do better or worse, you can really start to see some differences in depression symptoms, at least, by people getting their predicted optimal treatment versus their non-optimal kind of treatment. One of the interesting things, or one of the cool ways that people have taken this is to really like say, you can plug in some of your patient's data to see what treatment you might recommend. So I'm going to click this and we'll see if this works. So what we're looking at here, this is from one of my friend's papers, basically letting you plug in your patient's data on these predictors, on these different measures that have been shown to influence or predict what treatment package a person might benefit from. So these are things you can modify, how severe your patient's depression is, some specific items of depression, like how fatigued they are, how much difficulty they have concentrating, how much anxiety they're having, whether they have relationship problems or not, whether they have borderline personality features, asking them, like, do you think you're going to get better or not? So if they don't think they're going to get better. And these other factors of trauma, OCD, et cetera, you can even scroll down here to see these different ones. And you can ask this little app to give you a sense of how you think, how it thinks people are going to do in a various treatment condition. And it will show you here kind of like how much each of these variables contributes to their predicted outcome. So it'll give you here kind of their predicted post-treatment score, as well as some confidence intervals and bands for how well someone might do. So this is just one example of, and again, this is one study. So these are things where we need more data. We need these larger data sets to see if these really are the optimal set of predictors that can be used to predict someone's outcome, or if we're kind of overfitting our models given smaller sample sizes in treatment research. But it at least points in the direction of, if we can start to do this, if we can find some of these predictors that do generalize from one study to another, that there might be some really good indicators of, more reliable predictors of treatment success in different conditions. So if you can predict, if you can say, okay, this patient I think is going to benefit more from cognitive processing therapy than prolonged exposure, then you might ask, okay, well, like, what aspects of cognitive processing therapy should I actually be including? Do they need the whole package or not? So some folks have looked at this in different ways. Apologies for the train behind me. One really influential that you probably have heard of before, I would imagine, is Project Match, which stands for the Modular Approach to Therapy for Children. So in this study, what the researchers did was first just did a survey of the literature to find out how many tools, how many components were included in efficacious treatments for, in this case, anxiety disorders. And so they said things like exposure, psychoeducation, coping, self-monitoring, tangible rewards. These things are in almost every efficacious treatment for anxiety disorders. So we think, like, if we're going to make, if we're going to make a package of treatment for anxiety, it should have those things in it. And it should be for kids who have, primary anxiety. And you can do this for depression, for trauma, for eating, all these kinds of difficulties kids might have. What they found when they compared these kind of this modularized therapy approach to treatment as usual was a not insignificant, a nice moderate effect size difference in kids' symptom severity. And this is, standardized symptom severity across these different depression, anxiety kind of metrics, that after a year and even after 2 years had lasted for kids who got this match therapy as opposed to the standard kind of standard of care. So this is suggesting that, okay, if you can do a nice literature search, there's, beginning evidence that you might be able to identify some particular aspects of treatments that are more effective or more efficacious than others. And so if you can, include those in your treatment, that might lead to better, more longer lasting outcomes for kids. Another way to do this is this dynamic assessment treatment algorithm, or the DATA algorithm. This was developed by some folks out of Berkeley. And with this, they really capitalize on the idea that we know that patients are on wait lists. And so let's have them give us real rich information about their lives while they're on the wait list. So with this, you require people to give you 4 weeks of reporting on their symptoms multiple times each day. Not only their symptoms, but also kind of like some of their other behaviors that are going on. From this, you can figure out what symptoms kind of hang together and which ones are most impactful, which ones are kind of driving folks' clinical predictions, clinical outcomes. And then you try to match the therapy modules at your disposal to those particular impactful symptoms and order those modules to address the most impactful symptoms first. This looks like a very complex kind of, if-then kind of study flow. But really, if we look here, what you can look at are these. So for instance, under module 1, this blue box asks, did participants show compliance with the EMA protocol? If they did, okay, you might not need to do anything to enhance their motivation because it seems like they're really motivated. They've been doing this for 4 weeks, so they're ready for treatment. But if they didn't do it, maybe you do a module that helps to enhance their motivation for treatment, for care. But then what you do is you assess the model that you have from the 4 weeks of data, and you pair each factor, each kind of impactful factor of symptoms and outcomes with a module. And I'll show you in a second kind of like how they match these things up. And then you order those modules, as we'll talk about in a second, based on which one corresponds with the most impactful factor. So what that might leave you with are a set of modules that, again, can address cognitive, behavioral, kind of mindfulness kind of interventions. That's what I mean by modules, or specific kind of tools and techniques in therapy that are designed to be matched to a patient's presenting problems that they've been naturalistically experiencing. The way that they set this up is by kind of putting their heads together and saying, okay, well, I think this skill module of mindfulness addresses symptoms of irritability, restlessness, hopelessness, things like that. So if those are important for this person, if those are driving a lot of their other symptoms, we should probably put mindfulness up front, make sure it's in the treatment package. But if those things are not there, if someone's not really irritable, not really restless, it doesn't really do much for them, but they're actually feeling more worried and worthless or guilty, let's not give them mindfulness, and let's just give them cognitive skills or behavioral skills. So you can really then select, and that way you select which modules might be most important, and that way you're not spending a lot of time on stuff that a patient's like, why are we doing this? Like, what am I supposed to be getting out of this? They're like, no, clearly you've shown that these are problematic symptoms for you, and we think these modules are going to be most helpful to target those problematic symptoms. Then here just is a nice graph to show that doing this does lead to nice, reliable change in depression and anxiety for folks that gets maintained over 10 months or so. And interestingly, even though there was kind of an algorithm behind the scenes to guide this, the researchers also gave the original data to just a bunch of clinicians and therapists, kind of told them in general what this information was, and asked them to kind of compare how they would order the modules compared to how the algorithm does. And patients did just as well in both of those conditions, suggesting that here's a situation where if you can get a lot of information from patients on the front end about what seems to be impacting them the most, clinicians might be just as good as computers in saying, okay, well, this particular aspect of irritability or restlessness seems important. Let's do this. Let's use this module to target it. So score 1 for humans for once. Another way that we've been researching how to pick these tools is, again, kind of using this treatment called the Unified Protocol. This treatment is a transdiagnostic treatment for emotional disorders, so anxiety, depression, trauma, OCD, borderline personality, things like that. And it consists of these 5 core modules. These modules, understanding emotions is basically psychoeducation, mindful emotion awareness is mindfulness, cognitive flexibility or cognitive skills, countering emotional behaviors are behavioral kind of opposite action types of skills, and confronting physical sensations are these interoceptive exposures, so getting you to feel physically some of the sensations associated with anxiety to get used to it. What we found here in a recent study that's under review is that, so on the left, all of these modules were predicted to show decreases in anxiety pretty similarly. There's not a lot of difference. This is scaled in a way to just show this difference, but these modules aren't so different from each other. That pretty much if you give someone with anxiety any of these modules, they're likely to show some improvement from one session to the next. So you can imagine that just building on itself over time. However, if you've got someone with comorbid depression or someone with full depression and you're really trying to target depression, any of these modules except for the confronting physical sensations module, so the one where you're really targeting the physical symptoms of whatever emotional disorder you have, any of these other modules are likely to get you similar bang for your buck on reducing depression symptoms, but the confronting physical sensations one probably is not going to be that helpful for a patient. So you could even rule that out from the start and be like, we're just not even going to do this. It doesn't really make sense to have depressed people like spin around in a chair or breathe through a straw or like hold heavy things to feel really weighed down. We can just do other things and spend more time on these other skills that might be more beneficial for them. And then finally, when we're thinking about what tools for patients, another way to look at this is some other research we've been doing recently in our lab, looking at how to personalize treatment based on people's personality. So here there are, as you may or may not be familiar, there's this idea of the big 5 personality dimensions. So these are dimensions of people's personality that we seem to use pretty much across different people to describe each other. So neuroticism being people who are experiencing frequent and intense negative emotions, conscientiousness, so people who are really dutiful, get things done, are timely, goal-oriented. Someone who's agreeable, so really warm and trusting. Extroverted, really social, really positive and positive emotions. And then openness, someone who's like really open to different ideas and different kind of creativity or creative kind of outlets. So you have these 5 different dimensions. And so you can imagine designing a treatment that is tailored to people based on where they fall on these different dimensions. So for instance, if you've got 2 people here with personality profiles, so the person on the left is high in neuroticism and disinhibition. So they're very impulsive and they feel a lot of negative emotions, but they're not really antagonistic. They're actually pretty warm, trusting people. you might say, okay, so what we're working on now is designing modules to say, let's target that neuroticism and that disinhibition, but let's not waste time on improving their sense of trust and warmth and things like that, because they don't need it. They already got it. They're good at it. However, if you've got someone that's high in all three of these domains, it may make sense to give them a full course of care that with modules that target all of these different areas, because these things naturally are going to impact each other. You can imagine feeling negative emotions in social situations and reacting in an antagonistic way and feeling really impulsive while you do that. So all of this might be wrapped up, and you might need to give that person a really comprehensive treatment package. Whereas someone else, you might be able to say, you know what, let's leave out some components for you just because I don't think it's going to be necessary or relevant. Again, all in the spirit of decreasing how much time people are in treatment, making it more efficient, which has the downstream consequences of getting people out of therapy faster so that more people can then get in and access therapy. All right, so I've already alluded to some of this, but another aspect of these clinical decision points are putting these tools in order. So once you know, again, from the last person, we can say that we want to prioritize neuroticism and disinhibition and not worry about antagonism. What are we going to do to put these? How do we determine like what tools to start with? Do we just pick one and go with it? Or is there any research that can kind of guide how I do this? So I'm going to harken back to the data algorithm for one idea on how to do this. And so as I mentioned before, you can again say, okay, I see that this person has a lot of negative emotions, is really irritable, is really restless. Let's prioritize, let's front load the modules that deal with that so that we can hopefully get more bang for our buck. Like if that restlessness is leading to fatigue, is leading to concentration difficulties, is leading to interpersonal dysfunction, we should probably target that first. Target kind of the source of this difficulty with our mindfulness skills or whatever skills we think are targeted, whatever modules we think are appropriate for that. That way we can kind of knock it out on the front end and we can reap some of the benefits later on that might resolve if they're not having some of that restlessness going on anymore. That is a little bit of what's called like a compensation approach. This idea that we should help people target the thing that's getting in the way for them the most, or that they're worst at. So that can be contrasted with a capitalization approach. So capitalizing on people's strengths or compensating for their deficits. Here, it's all about this question of what do I start with people? Do I try to say, what are you already good at? Let's help you be better at that with this specific problem? Or do we ask people, gosh, what are you not really good at? Let's help you to really up your game in that area. And that way, if we can remedy that deficit, you can pull from your other strengths and probably get better faster. So it's these really competing models of like of strengths versus deficits of what you want to start with. You can have in your own mind your hypothesis about what this would be. The two lead authors on this original study were my advisors in graduate school, and each of them took a different side. One of them thought capitalization, one of them thought compensation, and they were like, let's do the study to find out. Let's pit them head to head. So they treated folks with depression using this approach, and they actually found that the capitalization model won out in that people got better faster on depressive symptoms and then maintained their gains, their kind of like improvement relative to the compensation condition over the course of therapy. So this would suggest that if we do kind of front load skills that people are already kind of good at, but we help them to apply those things to their, kind of like most pressing issues, that they don't have to reinvent the wheel. They can simply say, okay, I kind of know. So for example, take someone for whom cognitive skills are a strength. You could say, okay, you're already really good at like thinking things through and like looking at different sides of an issue. Let's help you do that with your depression, but let's help you do it in a really useful way rather than spinning your wheels or kind of like asking a lot of what if questions that just distract you. rather than saying, well, you're really good at cognitive stuff and you're not really mindful. Let's just sit you down and really help you, like, let's give you a ton of mindfulness meditations to just like sit and be and not have to think about other things. They may say, I'm not really good at that. I don't want to do this, and I'm not getting any benefit from it, or as much benefit. However, I will put a little bit of a caveat here. This was a smaller study, and when we tried to replicate it in our lab using a slightly different approach, taking people's kind of self-report questionnaires, we found no significant differences between these different approaches of capitalization or compensation. That might speak more to how we measured strengths and deficits for people. So we do encourage more research on this, but you can kind of say maybe start with strengths, and it may not be the be-all, end-all yet. So stay tuned for more of that. So you've got your treatment package, you've got the skills you want to use, you know you probably want to start with capitalizing on their strengths, and then kind of working through the skills that your data algorithm has told you. Now you need to know, well, like, how often are we going to meet? How are we going to do this thing? Good thing here is the research on this is pretty clear that more frequent sessions are better. And so people have looked at this in a couple of different ways. I'm going to highlight a couple of really nice studies, but these are definitely not the only ones. There's some good replicable evidence for this. So in one study, people were given cognitive behavior therapy or interpersonal therapy for depression, and were given it either once a week or twice a week. And they were given the same number of sessions and then followed up for the same amount of time. So basically, the people that got sessions twice a week came to therapy for like fewer calendar months, but then were followed up for the same amount of time as the folks who came once a week. And so the once a week people are the solid lines on top, and then the twice weekly people are the dotted lines on the bottom. And these are, depressive symptoms here on the y-axis. And again, pretty clear evidence, kind of similar to the strengths versus deficits, where the twice weekly folks got better faster. Again, even though this timing is, even though the session here on the bottom is all about time in treatment rather than like sessions per se. If you front load people, you get them in 2 times every single week, and then let them go. Even though someone else is still in therapy for once weekly sessions, your twice weekly people might continue to get better and might continue to see improvement compared to your people that you're still seeing once a week as they're going through their treatment. The same pattern has been shown for folks doing cognitive processing therapy or prolonged exposure for PTSD. Again, taking a once week or twice weekly approach, you really see a fast decline in folks' PTSD symptoms for those who go through twice weekly. That then persists over the course of the assessment period. I realize this isn't always manageable for folks or a thing that you can do given your caseload, but if you can, encouraging people to come more than once a week and knowing that, okay, we'll give you the same number of sessions, but we're just going to cram it in faster, that may actually help people. We think, in part by enhancing like kind of their learning, by giving people more rapid corrections to their therapy skills to help them apply them more effectively. And just kind of getting a more steeped into therapy, that may be what's driving some of these outcomes. So you're in therapy, you've got your person in therapy, you now need to know, you're doing twice a week if you can, you've got their modules set up. How do you know when you're done? So one of the interesting things, right, we design our therapy treatments to be 12 or 16 weeks typically, but that's only because that was the length of drug trials originally. And so we wanted to compare, okay, well, how do our psychotherapy treatments compare to drug treatments? We need to deliver both of those over the same amount of time to make a direct comparison. But there's nothing magic about 12 or 16 weeks. Someone might leave treatment early because they're better. Someone might want to stay longer because they're not better yet, but if I do get a little more treatment, I'll be better. So it's up to you as the therapist to try. Well, it's not always up to you. It's up to you, the patient, and the patient's healthcare provider or insurance provider as to when you're going to stop treatment. But if you can think about it, I want to talk through some of the research on when you might end. So here is a nice graph of our results from a recent trial for folks with anxiety and depression. What I've illustrated here, so this blue line, just indicates the average group score on how severe their anxiety is. These bars indicate what percentage better they are. And so this is all anchored on kind of their final session anxiety score. And then this dotted line indicates the clinical severity cutoff. So you can imagine saying, well, as soon as my patient drops below the clinical severity cutoff, I think we're good. I don't think we need to treat them anymore. You could argue, well, we need to do 12 sessions because this is a 12-session protocol, and so I want to see them through to the end. You could argue that, like, well, when they're at least some percentage better, they might, if I just stop treating them now, they might continue to get better even if I'm not doing anything anymore. These are all totally open empirical questions for how to figure out when you're going to end treatment, and all reasonable things that people do. One way, this is I'll show you kind of a counterintuitive, relatively complex graph that we're still trying to parse through a little bit to ask some of these questions. So here, what you're looking at are 3 groups, well, really 9 groups, but 3 groups of people, those who had high anxiety scores at session 6, medium, and low scores. And then within that, people who had really fast change at the start of treatment, kind of the blue are more moderate change. And then the black are actually people that got worse at the start of treatment, that they started one anxiety score and then they actually got higher. This seems to show that, okay, across these 3 groups, if you've got someone who has a lower anxiety score at session 6 than most people you've seen, you probably can let them go. What this is predicting is their anxiety score at session 12 or week 12. So if they've got a relatively low anxiety score at session 6, they're probably going to have a low anxiety score at session 12, regardless of how they've done before. However, if they've got a medium anxiety score, you're not exactly sure, what do I do with them? Another question can be, has their score been rising or falling over the past time that you've been meeting with them? This particular result would suggest that if their anxiety has actually been kind of going up over the course of your meeting with them, but it's still within that medium range, you might be better off letting them go. And that might just be because they're kind of facing their anxiety, they're really engaging with it, and so it is ramping up, but the skills that they're learning are likely to pay off if they keep applying those skills when you let them go. Whereas someone perhaps who has experienced this really fast change, they might not have been engaging as much. They might still be doing avoidant things to keep their anxiety at bay. And so even though they're at kind of a moderate score, you may want to keep them in treatment to make sure that they're applying these skills more effectively over time. All right, so takeaway points from what we know so far. Picking a treatment package, there are data-based methods, and these can really show some nice big effects. So you might be inclined to use some of these machine learning algorithms if you can. If you can't, you can, of course, talk with your patient about what might work, knowing that that may not impact their outcomes, but it certainly might influence how satisfied they are. And also there's the question of what treatments are actually available. Can you as a therapist or your therapeutic team provide these different treatments? For identifying which tools for which patient, you might start with some core modules. So you as a therapist or you as the treatment team might kind of know, okay, these modules seem to work for most people. Let's have those at our disposal. But if we need to, if someone, for instance, has anxiety and not depression, we should probably do that interoceptive exposure, that confronting physical sensations module. We should probably add that on if that person has anxiety in the picture. But if not, we may not need it. If we're going to order our tools, let's front load their strengths and then try to target things that have the widest impact. If possible, let's meet as frequently as possible. Let's meet twice a week instead of once a week, or once a week instead of twice a week. Kind of like, think about that. And let's, focus our schedules as a clinician so that I can prioritize that. And then finally, when we're figuring out how to end, if someone's reached that clinical threshold or their target score, or they have kind of a lack of improvement so far, we might think about how do we use kind of like step-up care, other models of care, so that patients get the kind of treatment that they need. And you can really see how do they benefit from different levels of intensity of treatment. All right. Thank you guys for such a lovely, for being such a lovely audience. I am very excited to hear any questions, comments, concerns that you might have.
Thank you, Matt. We don't have any questions at this time in the chat. Feel free to utilize that or unmute. Oh,
I have a question. So, hi, Matt. Thank you. That was great. Wonderful work. Exciting and has enormous potential. So I'm wondering if you could talk a little bit about what it would take to take this kind of thing to scale, right? So, because a lot of folks in the the TCOM community, which you have a lot of listeners from, we do these big scale projects where there's a lot of different people participating and so forth. And the approach is really fascinating. I think there's enormous potential. So how do you actually think about taking this and applying it more in like a entire system by therapists at a time?
So, I mean, I think it would, I'm certainly not an expert in whole system care, so I will defer to some of you on that. From my perspective, but it would involve the whole system, of course, to make this kind of thing work at scale. So it would involve things like determining good measures of outcome, first of all. So what do we mean by that? Do we mean symptom measures? Do we mean quality of life? Do we mean functioning? Do we mean satisfaction with treatment? Once you kind of have that in mind, once you have some agreement in your healthcare system on that, some of the questions would be, okay, how do we make people's schedules? How do we make therapist schedules if people are going to do therapy? How do we make their schedules most amenable to some of this more kind of condensed treatment? Similarly, how do we standardize some measures that this research can show might help us to predict what kind of treatments can be most beneficial for people? And so then you can think about having a system set up where, patient contacts your system, they're automatically given measures that are going to be helpful for predicting outcomes. You feed that into these algorithms. The algorithm spits out kind of what modules are important and in what order. And then you can deliver that, or the therapist can just print that off and say, hey, here's kind of what we're thinking. You might do some shared decision making. Does this seem to make sense to the patient? And if they're in agreement, then you can really go with that. And again, try to schedule things so that people meet more frequently. I think that is kind of a dream at this moment. You could also think about fitting in different levels of care, as I kind of alluded to at the end. So you might start people, regardless of what their presentation is, with more of a guided self-help kind of approach, or a bibliotherapy or an app-based kind of approach, and see, do they benefit from that before they even see a therapist? That way, again, as the system, you are front-loading people with really easy, disseminable, evidence-based kind of treatment options. If the person takes to it, great. Then they may not even need to see a therapist, or if they do, they don't need to see them for as long. But if not, then it's really easy to step them up once their wait period or once their trial time with that kind of app or guided self-help is done. Then you can step them up to actually seeing a therapist in person. I do think, of course, it does involve like more of a top-down approach of saying these are our priorities, and then asking how then are we going to meet those priorities, and trying to make the structure of the system work to meet those priorities.
All right, sir. It looks like you have a question on the chat. This is from Janet Hecky. I am interested in what you said at the beginning about the transition in payment models from fee for service to value-based. You indicated one of the value criteria is that patients feel better. It seems that patients sometimes don't feel something is particularly helpful at the time, but it turns out to be very helpful in the long run. How does this play into the evaluation criteria for value-based payments?
I think it's such a good question, especially in this field where, like, if we were doing like objective physical measurements, then it's pretty easy to say, yeah, this person has reached this threshold or not. But when we're using more subjective measures, I think it's a totally fair question. I think like we are constrained in some way. The value-based care model is limited to just an assumption and an agreement that these are the measures we're going to use. So for example, we're going to pick an anxiety measure or a depression measure that does seem to decrease with effective treatment. Yes, there may be people who, as you rightly point out, might be like, oh, this is, for someone with anxiety might say, this is too much, this is too fast, my anxiety is spiking, I don't want to do this anymore. And then that would lead to, kind of like a bad score for that therapist or for that healthcare system. And thinking about just, again, at scale, those people that's probably going to be a pretty limited share of people that are going to respond in that way, especially if some of these personalization algorithms and things are actually translatable. So what should be happening then is, like, if someone does kind of have that tendency perhaps to respond, to kind of like really respond, kind of react negatively to that kind of care, they may actually the algorithm may predict them to get more of a gradual ramp up of certain skills and modules. So they might start with some motivational enhancement, some kind of like tracking of their symptoms, and then kind of like easing into, okay, now are you ready to progress to doing some exposures and things? And that would help the therapist on the front end to build rapport. That would help them to kind of like understand where this patient might be coming from, that they might be a little more hesitant. And so that can also help to decrease the likelihood of getting those kind of responses from patients. Again, I know neither of those are like perfect answers to that question, to that problem, but I do think there are ways of kind of mitigating its impact, its kind of like big picture impact on a therapist or on healthcare providers' kind of score on these metrics.
Matt, I've got a question. Do you know if any, you mentioned personalization based on personality and treatment presentation, things like that. Do you know of anybody that might be doing personalization based on like social needs or social determinants of health, or if that's kind of factored into any of these models?
That is, so no one that I know explicitly. The closest I can think are, so some of the folks out at UCLA are trying to roll out this very fancy, very nice app-based version of some of these therapy skills with a like built-in kind of step-up procedure And their goal is to try to deliver this to folks in more like low income, low SES communities first, to see if it's actually relevant and useful for them. And if not, then to kind of, again, give them a higher level of care and higher level of services. So that's not speaking to like the personalization of pieces based on kind of these social needs or social determinants, but it certainly is like trying to deliver these things to folks that may traditionally be underserved in some of these ways. That being said, I will say, like with some of these algorithms, those factors are usually considered, or at least are like somewhere in the demographics form. So, and if they're not, they easily could be implemented that way. And if they're relevant, if they're things that like, the model picks up on, then it's a really easy way of saying, okay, like if this is something we should be, that can really determine what treatment or what kind of course of care or the duration of care is going to be impactful, we can easily include that in that kind of model. So it kind of gets back to measuring it effectively and prioritizing it.
Matt, I was going to ask, can you provide a link to the article on the machine learning? Did you say it was a paper that was published on that?
Yeah. There are a few of them, and I would be happy to send a link for that. I might do it through Diamond if that's okay.
Yeah, perfect. And just out of curiosity, the matching were they using machine learning for the matching, or was it just like traditional propensity score matching?
This was machine learning for the matching of the therapy to the patient.
Interesting. Okay. Yeah.
It's honest. I mean, it's been used now in a bunch of different studies, so I will send all of those. And then there's been a recent, unfortunately, those studies have been like applied retrospectively, kind of see, okay, like who would have benefited. And one recent version of trying to apply it prospectively found like a much smaller effect size of the impact. So I do think there still needs to be some questions about the generalizability of that kind of model, but I will definitely send all of that along.
Oh, thank you. Appreciate it.
Well, sir, I'm not seeing any more questions in the chat. So if anyone else has any more, please feel free to either speak their mind or say it in the chat.
We are at time, I think. So I have us 1 minute until till 3. So I just want to take this moment to thank Matt for coming and sharing your good work with us. I think there's enormous potential for these kinds of methods to advance practice in our world. And so I appreciate that. And to let everybody know, it's a dense talk, and we have recorded it, and we will post it on the YouTube channel. When is that going to be posted, Diamond?
Yeah, I've already reached out to Zach, and we are prepared to post it tomorrow afternoon.
Okay, so tomorrow, if you want to re-listen to it, or if you have friends that you want, colleagues that you want to have hear it, please share. So thank you, Matt. Well done. While giving you an internet clap, which is not nearly as gratifying as the real thing, but we appreciate it.
Thank you all for the invitation and for making the time and for being here for this. It's such a joy to hear from different people who are working in this kind of area, but in a slightly different way, and to hear like, okay, where do our interests align? How can we be most helpful for each other? I really, really value it.
I have the intention of reaching out and seeing if we can have a meeting with you and some of our group to talk about convergence.
That'd be the best.
All right. Thank you.